size of it. But anyway, that's what they do. And when I was hired, 50% psychiatry, 50% family practice was a blended rate, and they offered me $5,000 less a year than I would have made if I'd gone to Kaiser in adult medicine. And so Kaiser psychiatry would definitely meant more. Now this last year, Kaiser was less for adult medicine than it was when I came out. But they were offering, when I came out, 165. And I don't honestly know what they were offering in psychiatry. Because the only psychiatrist I talked with anyway, I didn't want to work. She was like, we have to be fast enough to see a patient every 6 minutes.
Jeez.
There aren't enough of us.
It's like dermatology.
Yeah, except, yeah.
So Cindy probably wouldn't exceed psychiatrist straight.
You, at this point, you'll make more in psychiatry. Will that change? I don't know. There's this little increase in primary care. If they don't increase it a whole lot more, there aren't going to be, there's not going to be anybody willing to do primary care. And, you know, I'm really curious how that's going to kind of sort out, how that's going to fall out. I don't know. We just, we have trouble recruiting. I know Kaiser has gobbled up as many primary medicine doctors as they can because they need them. So, you know, I don't know what will happen. Without healthcare reform,
Are you happy doing what you're doing then? The combined,
except that there's too much work. Come on, Jim.
Yeah.
I'm sorry, not enough work, what?
Yeah. I haven't figured out how to do this more efficiently. And it's the primary care that really, it's the primary care and it's the uncompensated work. It's the forms that they drop off. It's the last month and a half has been horrendous for the last month for prior authorizations. Over and over. And these are, 2/3 of them are medicines that the patient has been taking, like, been stable on for a number of years, but now they have a new formulary. So it's that kind of stuff, and the phone calls, and I think our system should be a little more efficient in terms of other people handling some of that. I don't really know how to do it. But I find for every 4 hours of patient contact, I usually have about an hour of cleanup of my notes. And I think that's actually pretty good. 4 hours of patient contact, an hour to finish up the notes you couldn't finish because somebody needed a little more time, you didn't quite get it done. And then there's usually an hour of this other crap. And so it's 8 plus 8 plus, I'm sorry, 4 plus 4, each half day, plus 2 plus 2 makes a day that's too long.
So there's no administrative time, basically. It's just see how many patients you see in a half day.
You know, it varies. I have set my psychiatry schedule. I do 30-minute follow-ups with an occasional 15 that I put over an FP clinic, like I've diagnosed some ADHD, adult ADHD, and they're really stable and very uninteresting and everything. They're just doing fine. I mean, there's nothing going on. They're fine, they're stable, no changes. So I see them in med management across the hall. But I do mostly 90805s in 30-minute slots. I allow an hour for an intake, and if anything, I've gotten worse at doing it in an hour.
Wow.
And I do some psychotherapy, some 45, 50-minute psychotherapy. 1 or 2 to 3 patients at a time. Right now I have 2. Something you can't do in Kaiser. In an FP day, it all depends on how many 30-minute new patients there are. So it varies from a low of 8 to 10 to a high, maximum would be like 13 or 14. A 28 patient day is brutal. 20 patient, 10 a half day, I can handle pretty reasonably. Today I ended early, and I had 16. I did 9 this morning. I had a well-placed no-show.
Well placed in them show.
But then my 23-year-old MBA with back pain had 30 minutes allotted, and he took about 45. So, you know, I lost whatever I gained. So it basically, a full day for, on the FP side, 20 to 25 patients a day.
So it sounds like, you know, the way I've sort of looked at combined training and sort of the folks who might end up doing it in the long run, you know, I've always thought of it as the way you increase your chances of actually doing that is if you really see yourself as a primary care doctor, really enjoying that, and then sort of your hobby was psychiatry, and that then kind of picks up as you go along and you really like it. But what's going to stop you from going completely over is that intangible need to be that primary care doctor and that interaction and that sort of thing.
And I think you're right. If you don't have some kind of passion for primary care, there is no point in doing anything other than practice psychiatry. With the one caveat that if you know enough about the practice of medicine, or if you know as much about the practice of medicine as you learn in combined training, you might be uncomfortable about having the ashen-looking guy come into your office and you just say, all you can do is call 911. You know? I mean, because that's kind of wimpy.
Unless you didn't have your staff, and if you didn't have the...
Well, I know, but that's what I want. I mean, this is not a guy, it's not wimpy if he's having cardiac arrest, but if he's just not doing well, yeah. Yeah, John?
Yeah. What's your, you might have mentioned it earlier, but what's your payer stats? Like, what's your payer mix for your clinic in terms of Medicare and
We are a majority insurance company, capitated HMO, PPO, I kind of lump them together.
so you have sort of umbrella that
We do significant Medi-Cal, so my guess is, you know, somewhere in the 10-15% Medi-Cal, somewhere in the 10-15% Medicare, maybe it's 20-25%, maybe Medi-Cal's more like 15-20, I'm not sure. Probably capitated HMO, other HMO, and PPO are in the order of 60-65%. It's kind of my guess. I like the mix, and in psychiatry, I particularly like the mix because I have seen the most fascinating patients. And maybe it's because I just saw so much of the seriously mentally ill, and yeah, they're interesting and all that, but I have seen such a range of psychopathology among the functional working folk. We do not see Medi-Cal psychiatry because there's a contract with County Mental Health to see all of them. But they dump a lot of those issues on the primary care doc. And so there have been many times when I have had to, when I've seen as primary care and I've helped other primary care docs see a patient with pretty severe mental illness who couldn't get into the county in a timely fashion.
have you seen a change in the practice of your primary care colleagues in addressing psychiatry since you've been there, or have you formally addressed that?
No, but I've been very much remiss in not doing the talk that was asked of me, because there's a lot I see, there's some very simple things I see that the primary care docs should do better and could do better. But one of the things that's definitely part of my model of practice is that once somebody's stable, they're out of here. Of course, half the time, they're out of here, and then the next month they'll be becoming stable again.
Yeah.
That's happened a lot. And then I had one gal who was stable, sent her back, a year later something happened, she got depressed again. and that's fine, but I really don't want to see